This is not magic. This is science. You know, no faith is required. And taking the pressure off of yourself before you go through this.
Three, two, one. Liftoff.
Welcome back to the Ketamine Startup Podcast. This is where we talk about how to build a ketamine therapy practice, industry insights, and what's shaping the future of psychedelic medicine. I'm Kim Ko, and this is part 2 of our conversation with Charles Miller from Scenic City Neurotherapy. If you missed part 1, Charles presented his controversial collective lie argument that our field's emphasis on ketamine experiences might actually be reducing treatment success rates. He walked us through the neurobiology, explaining why he believes the post-treatment neuroplasticity window, not the psychedelic experience itself, is where the real therapeutic action happens. Today, in part 2, we're continuing the conversation. You'll hear Charles detail his MSKIT protocol, minimally stimulated ketamine infusion therapy protocol, including his recs for administration, patient education, and more. We'll also explore his vision for where ketamine therapy is heading and why he thinks rigorous protocols matter more than experiential approaches. Just like in part 1, you'll hear me pause occasionally to provide context through audio sidebars, moments where I explain research studies or complex concepts that might help clarify what's being discussed. But before we continue our conversation, a quick disclaimer. The information shared in this episode is for educational purposes only and don't constitute medical or legal advice. The approaches discussed reflect individual provider experiences and should be evaluated with your own practice context and regulatory environment. Now we pick up with Charles explaining his philosophy about when therapy should actually happen during a ketamine treatment and why he believes the timing makes all the difference for patient outcomes. Now let's dive in.
I think the psychotherapy is the most valuable piece. I think it's more valuable than even the ketamine. But I don't think it needs to happen when the patient's altered. And we don't need to over-focus the ketamine component on the experience. Like, they need to do the work with therapists when they're sober afterwards. Like, physical therapy doesn't occur during the surgery. It happens after. So, it's like a knee replacement is exactly that. It's, we're fixing the anatomy. It doesn't mean they're ready to get up and run. Even though the anatomy is functionally perfect, they have to build it.
When would be an optimal time for the therapeutic component? So it's not during the surgery. Is it, from what you've seen, is it 24 hours post-infusion, 48 hours, a week, 2 weeks? What are your thoughts on timing of that? What you actually, recommend?
With our practice, we recommend in the weeks that follow. And the reason being is that maximizing plasticity is the goal, but plasticity is the ability to adapt. It's not the adapting itself. Allocation of that plasticity, the assigning of the pathways. And that happens weeks to months to even potentially up to a year later. It's like, that's like, once you build, so we do a series of 6 infusions, like so many do, over 2 to 3 weeks. They're spaced specifically to keep optimal plasticity between, to where the brain can build plasticity is at its peak. The BDNF release occurs and the brain is building maximally between that 2 to 5 day window. And so we want to treat the patient again within that 2 to 5 day window. So twice a week for 3 weeks is what we typically do. And then we take 2 weeks off and then we evaluate. And then, so at week 5, we evaluate and we take PHE9s along the way. And so our study that we are actually publishing has demonstrated, when we focus every aspect, administration, route, duration, focus, and education of the patient on what ketamine is doing, but what we know it's also not doing. When we tell them, it's like, you can't make this work better. You can't make it work less. This isn't something you're doing, something happening to you. It helps them realize they can't mess this up. This is physiology.
Right, and less likely chance of failing at it necessarily, or they don't have that.
Well, it's like, you remove that pressure from it, the patient will lay back, relax, and let their brain build. And then, once we build them to a certain point, they just feel better functionally. And then, once they're doing better, so it's time to do the work. At week 5, it's time to make sure we're paired with a therapist by that point, if we don't have one already. And now we hunker down, and it is time to work. It is time to look at lifestyle practices, coping mechanisms, healthy outlets, make sure all of these things, make sure the life they lead mirrors good mental health they want to feel. Because if everything sucks the right amount and your world sucks really bad, then you're going to feel that accurately. And that is
Yeah.
the benefit and the limitation of ketamine.
Yeah, and you highlighted something really crucial because in the paper, and specifically, it's because I'm a big believer of sleep and rest
Mhm.
post infusion and just in life in general. So tell us about how letting the brain rest, and having the patient sleep. What what is the importance behind that post infusion?
So there's no school that teaches ketamine therapy. Not like a school. Like we don't go, it's not a specialty or a graduate program that people go to. It's like we have to study this. And so you have to kind of follow the train of thought. If ketamine's primary goal is to stimulate a BDNF release in the brain, if that's our primary goal, if the BDNF is the actual actor that is improving synaptic processes and ketamine is the catalyst that gets it to release, then instead of studying ketamine therapy or ketamine itself, let's study the role of BDNF at the synapse. We should be looking there to determine what ketamine can and can't do physiologically. And the thing is that every day, your brain, as you're falling asleep, releases higher levels of BDNF. As the brain relaxes during meditation, your brain increases its BDNF secretion. Realize that's the value of rest. Is like, why do we rest? Well, that's how the brain builds. Now we use other things to clear waste products and do all that. That also happens while we rest, but that's just neurologic health. That's our brain turning over. What we're doing is think of you're using your brain all day long, and when stress exceeds a certain point, synaptic plasticity is lost, adaptability is lost through dendritic spine retraction. The brain literally is unplugging areas that are overstimulated. And then when we rest at night, your brain plugs them back in. And this is why sleep is so valuable. Well, if we're dumping BDNF on the brain, then you're not going to do a thing with that until you fall asleep. So if you're not sleeping well, then it's going to be, I mean, you'll still get good. It'll be slower. Your brain builds when it's in sleep mode. It doesn't build when we're using it, just like we don't do road construction on roads people are driving on. At least we should.
Let's take a moment to expand on BDNF and sleep, because this connection reveals a gap some ketamine clinics have as they approach aftercare. BDNF, brain-derived neurotrophic factor, as you know, is one of the key growth proteins supporting synaptic plasticity. It helps neurons form, strengthen, and reorganize connections. During a typical day, as you engage different neural circuits, some synapses are strengthened and others are pruned. Sleep is when synaptic housekeeping and consolidation occurs. Different sleep stages are associated with BDNF signaling changes, and good quality sleep is strongly linked to healthier BDNF dynamics. Now, bring ketamine into the picture. Ketamine triggers a rapid BDNF surge through glutamate signaling and mTOR pathways, creating the brief window of heightened malleability. But that plasticity needs the right conditions to more efficiently and effectively stick. Sleep provides that low stimulation environment where new patterns can get locked in. Now, why does this matter to you? Some ketamine clinics, and perhaps yours, take a purely medical approach. They appropriately focus on safe administration, monitoring vitals, safely sending a patient home, but that's it. No discussion of sleep hygiene, lifestyle factors, or even integration support. But if we understand the science Charles is sharing, shouldn't we be actively encouraging the behaviors that optimize this neuroplasticity window? Shouldn't we, and pardon the overused term, take a more holistic approach to post-treatment care, in particular in regards to sleep? If patients chronically shortchange sleep, especially in those critical days after treatment, they may be blunting that long-term gain that this plasticity window could offer. This is why post-treatment care matters as much as the infusion itself. You're not just delivering ketamine, you're opening a window of enhanced plasticity and then either supporting or ignoring what's happening with that window. Now let's return to the conversation.
So let's say that a patient undergoes ketamine therapy and they have, this like life-changing epiphany during their experience. But then they hear, hey, that epiphany, isn't the cause of your healing. How does one manage the conversation without devaluing that individual's personal experience?
I think the ketamine experience itself is retrospective. You can't have an epiphany. You can't learn
Mhm.
in that state. It can only reflect on what the brain already knows. So I have a patient that she was going through, and the whole treatment, she described her like she asked, I came in afterwards, and she was like, I thought of cheese the whole time, different kinds of cheese. And she said, what do you think that means? I said, do you like cheese? And she said, well, yeah, I do. My husband and I, we actually just got back from this wine and cheese pairing tour, and uh, through I can't remember where they went, but anyway, they just got back from a place where they were trying multiple kinds of cheese. It's the brain's noise. Things aren't so okay. I use my hand as the analogy here. So as an anesthesia provider, and under my understanding of anatomy, I look at my hand, and my hand, I understand the cellular makeup. I understand the muscles and the tissues and the tendons and the bones and all the innervation and the vascular, setup of my hand. But then you give me ketamine, and now I look at my hand. My hand is amazing. My hand is this extension of my existence. Do you see what I'm saying? It's like my hand becomes this amazing thing. It's not that they had an epiphany. And afterwards, I'm like, I'm still amazed by my hand. Because in that heightened suggestible state, with that loss of inhibition that occurs with any inebriant, but that's what's unique about ketamine is that you're highly suggestible in that state. And so whatever you focus on gains excessive meaning in your minimized state. Meaning that the brain's ability to process is not better, it's less. It's almost zero, which is why lights feel brighter, sounds feel louder. Your ability to tolerate movement or touch is limited, in that state. If we were enhancing processing, all of those things would be far more tolerable. The light spectrum would be better. We'd see, process more, see more. We don't. In fact, that's like something that's demonstrated. If you're looking around too much during your ketamine treatment, you're probably going to get nauseated because you can't process the stimulus as fast as just visual stimulus is occurring. We have to be very careful with that. I'm not devaluing it. Like, great. Somebody has the most beautiful, wonderful experience, no cheese involved. Like felt like they saw God, had this beautiful cathartic experience. And it's when I'm like, oh, that's so great. I'm so glad that was your experience. I hope that every experience is that good. Even though that's not the piece that fixes you, that's going to help you with your mindset over the next few days, just having that positive experience. Just like if I got on a roller coaster and I had this beautiful, wonderful, exhilarating experience, and I get off and my adrenaline's up and I just feel good. I can leverage that into better. That is a valuable piece, but it's a placebo component. Nothing has physiologically changed at that point. Knowledge does not change our ability to function. Knowledge is the result of our synapses firing. Not we don't think and then our brain writes. Our brain processes stimulus, spits out thoughts, feelings, reactions. We don't choose them, they're reflexive. And so, like, you don't have a realization and then that fixes your brain. Your brain turns off the noise and then you're just sitting with you and it's like, I am enough. Or it's not about me. Or like realize it's like they knew that already objectively, but the noise was always there. And we just silenced the noise with the ketamine.
So what I'm hearing is if the person does have some sort of epiphany like, "Hey, I am enough," or "I'm okay," or "I'm connected with God," what I'm hearing you say is that it's something that the brain and that individual patient already knew.
Yeah, they objectively knew it. So here's the problem is that when the people we treat, the people that do well with ketamine therapy are patients that look at the world. They built a world they want to feel. They just can't feel it. The feelings that are being spit out, like we're the stimulus processing machine. All the stimulus comes in and our brain processes it, almost all of it, without consciousness coming into play. We're experiencing our brain and making decisions. And then these feelings, emotional, visceral, and physical reactions just spit out of us. And if those match what we see in front of us, we never question it. Like if something horrible's happening, we feel horrible about it, then nobody questions that piece. But if we are sitting here and everything's good around us, yet we feel horrible, or we feel nothing, or something that should cause a level 2 stress spits out a level 10 stress response. Then we're like, what's wrong with me? Why is my body and brain reacting in a way that I objectively know is wrong for what I see in front of me? That is a mental health issue. We look at depression, anxiety, and PTSD and OCD and all the subtypes as if they're the disease itself, when really they're the symptomatology. What we're treating is not depression or anxiety or PTSD or OCD or any of those things. We're actually enhancing synaptic function. The brain processes faster and better. All of a sudden, it's the same programs that ran yesterday are running today. They just all run smoother, faster, with fewer errors. The responses we're getting match the objective perspective we see in front of us, because that's the way we're all wired to work. And when we lose that ability, that loss of function through that synaptic loss, then your processor gets overwhelmed. All of a sudden, what we objectively know is a level 2 stressor is taking enough energy of a level 10 response. And so it feels like a level 10 response, even though it's just my processing slow. It's not that the problem got bigger, I got smaller. And so what we're doing with ketamine is upgrading synaptic plasticity and adaptability of the brain. When we do that, everything just processes faster, smoother, and easier. All of a sudden, these problems that felt way big yesterday start to feel smaller today. They're more able to be present. Yeah.
Yeah, what I'm hearing is it's like a smoother functioning brain, and it's more it has more capacity to handle the level 2 issue without making it into a level 10.
If it was all about experience driven, then we'd have to have that experience every single day to be okay today.
The ketamine experience or the positive experience?
The ketamine experience or the positive experience. It's like we'd always be chasing that feeling.
Mhm.
And guess what? And anybody that's maintained boosters for any period of time will tell you it's that eventually the familiarity and the comfort with the process, it's kind of the same thing. Like you just it's like you're not getting new ahas or that euphoric feeling. Sometimes you do, sometimes you don't. Yet the benefit still occurs. Knowing that that there's 2 benefits to ketamine therapy. There's the experience, which is a momentary change in thinking, but it's not a rewiring. Then there is the synaptic plasticity, which allows for rewiring, but that rewires based on what you do later, not what you feel in the moment. Meaning that you can feel all the most beautiful feelings in the world during your ketamine treatment, but if you don't change your unhealthy habits or unhealthy coping strategies or bad lifestyle practices and do the work after, you'll just take all that plasticity we built and rewire the same old crap. And that's where people are getting stuck, is that when we focus on that, and then they have to keep coming back until eventually they can't afford it, or they just give up because it didn't last. And that is the big conversation, isn't it?
Hey listeners, this is Kim, and I just want to acknowledge that you're here for a reason. Maybe you're stuck in a cycle of long shifts, feeling a little burnt out, and wondering if there's any other way to practice medicine, especially on your own terms. We've been there, and that's exactly why we created this free checklist, your step-by-step roadmap to starting a ketamine clinic without those costly mistakes. Grab your copy now at www.ketaminestartup.com/checklist. It's completely free because we want you to succeed, not struggle. And hey, if you're driving or mid-workout, don't sweat it. Just check out the show notes for the link when you're ready. And again, that's www.ketaminestartup.com/checklist. Now let's get back to the episode.
Right. How do we make it sustainable? And, this actually segues into hey, how do we practically implement this? And so I'm curious, Charles, tell us about the MSKIT experience and what does that look like? And what does it stand for the audience who doesn't know what that means?
So MSKIT, or minimally stimulated ketamine infusion therapy. We created it and have been practicing it. And we have about probably 20 clinics in the nation that have adopted it as well, to focus all aspects of treatment on what we know produces the results we want long term. Meaning we always use intravenous administration. Why? Well, because even though intramuscular is bioavailability, it's bolus administration. And so there's no steady state blood level. Meaning when you do an IM shot, you get this big, whoa, blood level. It goes up and then it goes down. And you can get like, oh, well, I give 2 small ones. So it's kind of so it goes up in there twice and it kind of stays in that range. And that's better, but it's not optimal. The literature is very clear. Best results have always been found with IV administration, even if it's a few points, but most of the time it's 10 to 20 to 30 to even 40 points better. 40% better based on administration route alone. So everything we do with MSKIT is IV. Duration, making sure that the infusion, we hold the patient at that steady state for greater than 40 minutes. And that's the minimum standard we use at our facilities or for the MSKIT protocols. So it can be anywhere from 40 minutes to an hour to whatever your protocol is. We don't like to limit people too much, but realize that there's only so much BDNF you can release in a single treatment, which means that you can run them for 10 hours and you're only going to get X amount of good for that treatment. And so more is not better. There's the dose range. Now that 0.5 milligrams we see in research is always very helpful, but we do see repeated in the literature that 0.6 to 1.2 seems to be the sweet spot. If we go too much over that, we start to see actually improvement decline. If we go below those numbers, we see less as well. And so that seems to be the sweet spot, that 0.6 to 1.2 milligrams per kilogram per hour. And so we stick with that. And also the education. The education cannot be undersold. There's a whole educational platform that goes with it that helps the patient understand their role in this because they are the ones in the end that are going to make this work. We only make the patient process faster, which means they're only going to be as good as they actually are. So when we remove the limitations of that dendritic loss, as we optimize what's already there, they're only going to be as good as they can be today. And some patients will get there and I was here and then I'm 100 miles ahead of where I started in just a few weeks. And that's because that's where they should have been the whole time. But their own brain's ability to process and feel the world correctly was limiting them. And that's in the ketamine, when we turned it all back on, they got all of them back and they're happy with that. And their day-to-day life was already mirroring good mental health. So they don't really need to keep coming back for boosters and all of those things. They maintain well ongoing, indefinitely, even in many cases. Then you have those that, when we turn the brain on at 100%, it's like they're feeling correctly. It doesn't mean you feel good. If everything sucks the right amount and what you do, you just sit at home in the dark playing video games all day, that's supposed to feel bad. And you feel that. It's hard, it's harder to distract from that feeling. And so ketamine can make people feel worse if what they're doing should feel worse. It's not about feeling good. It's about feeling everything correctly.
Interesting. And so what about minimally stimulating? So is that look like eye shades? Does that look like earplugs, music, or is it
It's iCovers, a minimally stimulating audio list, which we let patients choose from, like binaural beats, something that is nothing you choose to listen to on the radio, but an understimulating overall playlist, just to kind of keep the brain in that neutral state. A lot like with the value of binaural beats, people attribute a lot of things to this frequency or that frequency. But the problem with music is that it's subjective. It's, somebody can, classical music's far too stimulating and other people can fall asleep listening to Megadeth. It just, there's different people and different tastes. But one thing that we do see is that repeating melody that moves around you, but that also changes with each round just a little bit. It keeps your brain looks for patterns. And so as the patterns change, we start to see, the brain kind of resets and listens. Like your background noise in your brain just kind of turns off. And while your brain's trying to follow that, even though you're not even really consciously listening to the music, it's just there. It helps kind of quiet the brain noise. Why it's good for meditation, or you listen to it when you're getting a massage, or, whatever. We use this music. The music is not a healing component, but it is a comfort component. And we call it minimally stimulated because because the brain, when it is less stimulated, it increases its BDNF release. Again, that's the goal of the treatment, is not to feel this or feel that. The goal is to stimulate your brain to react and respond by maximally releasing BDNF. And a relaxed brain is more prone to release BDNF. And if you study the BDNF in particular by itself, away from ketamine therapy, Like, you actually look at the literature, and there is so much literature on BDNF and its role in neurologic health. You start to also see what else we can address with ketamine therapy. It doesn't have to be just mentally health focused. We can address many different types of neuropathic pain, like phantom limb or complex regional pain syndromes, because they're also synaptic dysfunction. We can treat stroke recovery, traumatic brain injury. We can use it to address the neurologic loss that occurs with what we see with long COVID and other viral infections. This is neurologic health, and mental health is not so much the thing we're addressing. Mental health is the result of the way our brain sends signals to itself and the body. And if that's accurate, our mental health is good. If the responses are inaccurate, our mental health is poor. But what we're treating is a neurologic injury that affects the part of our brain that thinks and feels when we're treating mental health. It's like we're not treating the mental health itself. That's not a thing to be treated. That is, it's our own measurement tool.
Well, thank you for that description. And I did a little bit of research, and it looks like, you're combining, I don't know if it's in all patients, but NAD, lidocaine, magnesium, anti-inflammatories as part of
With our
your
pain protocols, yeah.
with the
Our
pain
pain
protocols.
protocols include all of that. We don't do all that
Sure. With
for mental
regular.
health.
Got
But
it.
like so ketamine does a great job from a chronic pain perspective. But, like I say, more is not better. Like, we do have a window to treat a patient, and it's a pretty big window. But they're also, we keep, throwing more and more at a patient. Ketamine is what we call a dirty drug. So that floaty feeling people get during a ketamine treatment is actually not from an MDA antagonism. It's from sodium channel blocking. It happens, the same feeling occurs with lidocaine infusion. Now, but lidocaine is an easier, better, safer way to block your sodium channels, which is why we use that instead of ketamine. It's a more effective modality. If we go too high with ketamine, there's a metabolite that builds in the system called hydroxynorketamine, which binds to sodium or binds to your opioid receptors. So this is where we see addiction potential with ketamine, is you're actually getting an opioid style addiction from, it's like an opioid dependency is developing physically from the ketamine, even though ketamine is not an opioid. It's metabolite, though, acts like one. And so, but an opioid is a safer, better modality than trying to just give these super high doses of ketamine that come with other side effects we don't want.
Let's pause here to unpack the specific pharmacology just mentioned, because this metabolic pathway is fascinating and is not widely appreciated by most providers on a day-to-day basis. Ketamine is often called a dirty drug in the pharmacologic sense. It interacts with multiple systems, not just NMDA receptors. Besides NMDA antagonism, it can also block voltage-gated sodium channels in a local anesthetic-like fashion, which may contribute to its analgesic and somewhat numb or disconnected quality at higher doses, on top of its dissociative effects. When ketamine is metabolized, one of its downstream products is 2R6R hydroxynorketamine, or HNK. In vitro work shows that HNK can bind to mu and kappa opioid receptors and act as an inverse antagonist in G protein recruitment assays, with these effects attenuated by naltrexone. In other words, ketamine's metabolite is capable of engaging opioid pathways at the receptor level, even though the parent ketamine itself has little direct opioid receptor activity. Charles' point that more is not better fits this emerging picture. At higher doses or with frequent chronic use, ketamine and its metabolites are present in the system more continuously, and opioid pathway involvement becomes more plausible as a contributor to reinforcement and dependence, especially in recreational patterns. So while ketamine is not an opioid, there is a mechanistic route by which repeated high exposure could tap into opioid-related biology. This is why pharmacokinetics and protocol design matter. At standard therapeutic doses, with appropriate spacing and supervised administration, available human data suggests low physiologic dependence risk and do not show a clear opioid-style withdrawal syndrome. But with recreational high-dose use or overly frequent unsupervised dosing, you're moving towards the conditions where opioid-like reinforcement and dependence becomes more of a concern. It's a good example of why understanding ketamine's full pharmacology, not just NMDA antagonism as the headline, really matters for safe clinical practice. Let's jump back into this conversation.
And so when we're treating pain, we use ketamine for the plasticity component. We use lidocaine for the sodium channel blocking component because when you block sodium channels, it essentially turns off your inflammatory cascade in the body. So it slows that inflammatory response dramatically. We had co-administer ketorolac, steroids like Decadron, even diphenhydramine, because histamine plays such an incredible role in our chronic pain conditions. We incorporate NAD in all of our infusions, including our mental health infusions, but mainly just because it helps stimulate ATP release, increases the removal of waste products in the body, helps you feel better, but it's just an adjunct. It's not a necessary component of treatment. But MSKIT up to this point, it's an adjunct that we feel is meaningful to help with recovery and short-term gains that lead to long-term improvement.
I want to shift our lens and look to the future now, Charles. So let's see, where do you think the ketamine field is heading towards? Let's say we're recording this in 2026. So let's say in 2036, what do you envision it looking like in 10 years?
Oh, goodness. What I'd like versus what I see. I would love to see that some real rigor put into the research. Less retrospective, more prospective, more critical eyes on the research. Because one of the things I do see is that I see a lot of there. While I'm a big fan of inclusivity in our space, there is a lot of people out there with no medical training, no pharmacological training that are administering directly all by themselves. They just have the patient get a prescription and come in, and then we'll do like a psychotherapy session while you're altered. It's the thing is if there is a medical emergency, which is incredibly rare with ketamine, it is hard to hurt somebody with ketamine, but these people find a way. The patient doesn't understand that more is not better. In fact, it is our natural instinct as humans to where if a little's good, then a lot's better. And what we see is in young, healthy people, more reactive airways have this risk of what we call laryngospasm. So I want to see that. I would love to see greater rigor in a space. I think administration needs to be managed by somebody who can manage an airway. That is something I'd like to see, at least collaboration to where somebody is present that can manage an airway. Doesn't have to be all driven by that person, but having access to that and safety, better safety, the take what we know and build off of it rather than try to reinvent something. Right now, we're seeing a lot of speculatory science in what like maybe it can do this, maybe it can do that, and I would love to see just significantly more rigor and very, very detailed roles set out so that therapists they have their roles. Physicians of different specialties have their individual roles in this process. One of the big things I hear from my psychiatrist colleagues, which I admire greatly, is that, well, I do intramuscular, or I do intranasal or sublingual because I don't know how to start an IV. And I'm like, well, that's a dumb reason not to do it optimally. Like, because we know, like, what if, so out of 1,000 people, if, say, you lose 5% on efficacy overall, with 1,000 people, that's 50 people that could have gotten improvement that won't. It's not who you're helping, it's who you're losing that needs to be the focus. Our goal is not to increase our efficacious number, it's to decrease our failure rate. And we need to be looking at that. They're like, oh, well, this is almost as good efficacy as this. Well, yeah, that's great. What's your failure rate? Well, who saw no improvement at all? Because there's this window between meeting that 50% reduction standard and people who saw no change or got worse. And that window is people who did good. They just didn't meet the standard at that point in the measurement process. They may have gotten there later. It's like, but they got better. Like we took somebody here and moved them forward. And so I'd love to see these protocols, some protocols adopted that really focused on the neuroscience and less on the speculative experiential component. I want the experience to be godlike every time. You and I talked about this. I've been through the ketamine process. Had another provider take me through back in January of 2020. And my personal experience with it was I'm a god in my own brain kind of thing. It's like I am the smartest, I am the best, I am the greatest. And then the ketamine wears off, and I realized that that was my own hubris. But like in our own heads, we are gods. Realize that. It's like, so ketamine is introspective. It's retrospective. It's like we're not seeing forward and we're not seeing out of us. We're only looking inward and we're seeing backwards. We see everything up to this point, and everything about our experience is influenced by the experiences of the last few days plus our history. So it could be focused on things we are actually worried about. It could be nothing but cheese. Yeah.
Yep, exactly. The time is wrapping up on our conversation, but I do have some more questions for you. So these are more kind of rapid fire fun questions. Charles, are you
Okay.
up for some?
Let's do it.
Okay. So for you, after a long day at the clinic, what is your go-to way to relax and de-stress and just chill out?
So in the summertime, I literally will go straight home and change my body temperature by just like jumping in my pool. It's not a big pool, it's a very modest little pool, and I jump in it. But changing my body temperature all over
Hmm.
is how I transition from work brain to home brain, because that is a hard thing to do, especially in the space we work.
Oh, so the pool is much colder, I'm assuming?
It's colder than my body, even on the
Okay,
hottest days. It's like
got it.
but it's all over your body. So changing
Sure.
stimulus all over,
Mhm.
physical stimulus. So you can do that in many different ways, like a
I
cold
love it.
plunge, or like when you change the stimulus of your body, your brain
Mhm.
hits the reset and says something has dramatically changed, and it looks for new.
Totally. Yeah, I
Mhm.
love that. I love how you're leveraging the sensory input with the neurobiology or the inputs into the brain to change kind of work mode to home mode. So that's a great idea. Do you have a hidden talent or hobby that most people would be surprised to learn about, Charles?
Surprised? Probably not. I'm kind of a dork with the science. I like to build software that I can use to disseminate data and research faster. Anybody that knows me well, it is the dorkiest thing I do. Um, but it is something that is how I spend my. It's also a distraction. So whenever I'm stressed over here, I have a hard day. Distraction is an excellent short-term coping mechanism, not long-term. I have to be careful about that, just like everybody. But in the short term, if like I just need to not think about this thing for 30 minutes, I can go get lost in my coding project, building a software platform like through or a server for data and research where I can quickly pull my answers or find these scholarly articles, um, and
Cool.
things like that. Yeah.
Yeah, I like your example of like doing something else that's less, I don't know, resource intensive. Mine is playing chess, so I'll play speed chess whenever I just want to get my mind off of something. Yeah, so I'll just hop on chess.com on my app and just play like these 3-minute, 5-minute, 10-minute, really short chess games, and it's a good way to get my brain. The distracted component is actually
Mhm.
what I'm seeking, I think, just getting distracted for a little bit of time. Charles, if you could go back in time for a day, where and when would you go?
Oh, for one day?
For
Do I have to
one
go back?
day, could go back in time.
Oh, goodness. I'd go back to when my kids were small. My children are 25, 23, and 17. And, every older person told you growing up that, your kids are going to grow up faster. I did all my graduate work, my education and training while they were young. And I would go back and I would sit with that. I just spent one day just soaking them up because that's
Hmm.
regret is the piece that you never want to have. And so that is I feel like I've done a really good job living my life. I'm feel very blessed. I feel very, very lucky to be me. But that is a piece that I don't
Hmm.
think I could have enough of and would always go back for more.
Yeah, that's beautiful. Thank you. If you couldn't do what you're doing now and for whatever reason you're not able to go into the healthcare field, but you have to have some sort of career or job, what would you do instead?
Okay, so I used to be a general contractor. I'd go right back to that. I love building, I love remodeling. It is something that I don't get any time to do now, and my efforts are better spent at my job, and I pay somebody else to do that. But there is so much satisfaction in construction just watching something go up that's permanent, that's yours. You did that. You can drive by and say, I built that. And so I would, if I had to leave healthcare and go into something totally different, I would so become a contractor.
Awesome. I mean, you're kind of helping patients do that with their brains too. So I can see the correlation there. So last question for you as we wrap up is, people who've listened to the podcast, watched the video, where can they connect with you more? Is there, social media, a website? Like, what's the best way for someone to connect with you and learn more about you and your research and what's going on in Scenic City Neurotherapy?
Our website, ScenicCityNeuro.com. You can go through that portal to get to us. We're our business, and it has links to our Facebook, has links, and from that Facebook, you can find my personal professional Facebook. I'm on LinkedIn. I'm real easy to identify because, if you look up me and if it says anything about ketamine, I'm pretty sure I'm the only Charles Miller in our space. So, but yeah, I'm on all platforms. I love conversation. I love questions. I love teaching. I teach this at the University of Tennessee in Chattanooga to their anesthesia undergrads or graduate students and to their psychology undergrads. And that has been something I learned that I like about. I never would have thought teaching was part of my future. But yeah, it's so if anybody has questions, criticisms, comments, I'm more than happy to address it in a very respectful but very direct way.
Well, thank you so much for your time. It's been an honor having you on and hearing your perspective. I think it's really good to have and bring people on with kind of a unique lens or something that kind of pushes back on status quo. And that's one of the reasons I wanted to have you on. So I know you've done a ton of work on this and research, like just based on our conversation, you've actually thought deeply and critically and analytically about this. So I do want to acknowledge you and say that I really appreciate the work you're doing, Charles. And thank you so much for being on the podcast today. For those listening, thank you so much for staying till the very end. It says a lot about you. And any last final thoughts, Charles, before we let you go?
I think one of the best things to remember about this is that this is not magic. This is science. No faith is required. And taking the pressure off of yourself before you go through this, so if you're the patient, even if you're the provider, realize this can do what it does, but it can only do what it does. Don't give it more credit than you should, but give it what it can. Let's best figure out how to leverage what it can do into better.
That wraps up our two-part conversation with Charles Miller from Scenic City Neurotherapy. We've covered his journey from cashing out his 401k to open up a clinic, to his controversial argument about the collective lying ketamine therapy, to the practical details of MSKIT protocol and his vision for the future of ketamine therapy and psychoplastigenic medicine. Charles challenged us to think beyond experiences and focus on the science. The NMDA glutamate BDNF pathway, the neuroplasticity window, and why rigorous protocols matter more than mystical insights. Whether you agree with his perspective or not, his research-backed approach offers important food for thought about how we're practicing ketamine therapy. Now, if you found this two-part series valuable, we'd really appreciate it if you could leave us a review on Apple Podcasts or Spotify. It helps other medical professionals like you discover these important conversations and grow our community. For complete show notes for both parts of the conversation, including links to Charles' research, the studies we discussed, and information about his clinic, Scenic City Neurotherapy, visit ketaminestartup.com/podcast. And remember, this podcast is for educational purposes only and doesn't constitute medical or legal advice. The approaches discussed reflect individual provider experiences and should be evaluated with your own practice context and regulatory environment. Thank you again for listening to both parts of this series, and we'll see you in the next episode.